So here we're going to cover cerebral arterial supply and neuroanatomy. We're going to go through the circle of Willis, the cerebral arterial territories, then the brainstem and cerebellar arterial territories, and then vasculature of the head and neck, and we'll skip some of these advanced topics that are available on the site. So let's walk through the circle of Willis. Internal carotid arteries on both sides, they give off the middle cerebral arteries and then also the anterior cerebral arteries. And then the vertebral arteries come up, they fill the basilar artery, which spits off the posterior cerebral arteries here. And then all of this is connected at the posterior commissures. So anterior circulation and posterior circulation are connected here. The right and left sides, however, are connected at the anterior commissure. So you can see that if a vertebral artery on one side is knocked out, the other side can come and fill. Whereas if an internal carotid artery here, for instance, is knocked out, there can be backfilling from the other side. So if there's slow developing occlusion of a carotid artery, even though it can be completely occluded, there are other pipes to fill its territory. Now let's go through some branches here. Anterior choroidal artery off the ICA and the lenticular striate branches off the MCA. We have the cerebellar arteries coming off here, superior, anterior, inferior, and then posterior inferior cerebellar artery comes off the vertebral artery. So in a vertebral artery dissection, you can get a branch occlusion of the pica here, causing a Wallenberg syndrome. The verts feed the anterior spinal artery here, and then there are pontine paramedian, short pontine, and long pontine circumferential arteries coming off the basilar here. Again, anterior circulation, ICAs, MCAs, ACAs, and then posterior circulation, the vertebral arteries to the basilar to the PCAs here. So let's go through these different territories here. We'll walk through this pretty quickly. So anterior circulation here, again, this is all posterior circulation here. This is the split for the MCA and the ACA. And starting superiorly, we don't see the posterior cerebral artery vasculature at all. It's not till we get more inferiorly that we get this division that includes the PCA. We can see that the PCA covers this back 1/3 of the brain. Remember, the occipital lobe is primarily and mostly for vision. So a PCA stroke, while it may cause confusion, the only deficit on exam may be a visual field cut. It's oftentimes we don't remember to do visual field testing at the bedside, and so an easy stroke to miss is a PCA stroke if you don't do visual field testing. And in a confused patient, that can sometimes be a challenge. This is the homunculus with the arterial supply layered over it. So we can see how the ACA covers the leg, whereas the MCA covers the arm, hand, face. So in an MCA stroke, the leg will be preserved, and this can be misleading. Folks might expect that if the arm is affected, the leg should be equally affected, but that's not going to be the case because the stroke is only affecting one arterial vasculature there. Okay, so let's look at some of these various potential strokes. So this is a left MCA M1 occlusion. This is the MCA territory distribution. This is the area of the stroke here. On CTA, we can see this thrombus, this flow void, this lack of filling here. This patient could potentially benefit from a thrombectomy where they channel in and go and yank that clot out. And then this is the deficit that you're going to see is going to be face and then arm and then potentially language production and language reception depending on where anteriorly and posteriorly the MCA is affected. And then this is just a scroll through of this territory of the MCA here. This is a small region of the MCA, so it's important to know that you can have these tiny little infarcts. So someone can have what seems like a non-localizing stroke where just a portion of the hand, just the medial fingers or something like that are affected, because you can have tiny infarct in this precentral gyrus in this motor strip. And so it can appear to be non-localizing. Posterior limb of the internal capsule, even though it's a small stroke here, it will knock out potentially the entire half of the person's strength because all of the motor fibers bundle here in this posterior limb of the internal capsule. So moving on, this is an anterior cerebral artery stroke. Again, the ACA covers the leg. So in leg weakness, think about an anterior cerebral artery stroke. This is a scroll through. We can see the hyperintensity and DWI here with diffusion restriction. Now, this is what's called a border zone or watershed infarct. So think about a garden, there's sprinklers. The perimeter of what the sprinkler covers is going to be the most vulnerable to a reduction in pressure. So this is the perimeter of what each of these sprinklers is covering, is this region right in here. So if there's cerebral hypoperfusion, if there's a loss of blood or a reduction of blood pressure, this is going to be the area that's vulnerable. It happens to map to the proximal limbs, so the shoulders and hips. So if the person has a stroke like this, they may be weak at the shoulders and hips, and they may look like they're in a barrel. So this is called man in a barrel syndrome. We talked about how in a PCA stroke, it may just be vision that's affected. So this is the hemianopia. Right hemisphere covers the left visual field, and we can see this visual field defect there. So now let's walk through brainstem and cerebellar arteries. So this is posterior circulation here. With the midbrain, we think about the PCAs. With the pons, we think about the basilar and its perforators. And then we think about, with the medulla, we think about the anterior spinal arteries. Now that's an oversimplification, and we'll see here that the brainstem has a lot of different vascular territories. This is just an example of basilar thrombosis. So if you have a stroke in the basilar itself, obviously it can be a quite devastating stroke. It's going to knock out these short branches here, and then it will knock out the PCAs and can obviously be life-threatening. Starting with the midbrain here, key vessels, the PCA and the basilar itself. The source arteries are the basilar here, the clinical syndrome, top of the basilar syndrome. So that's a midbrain infarction. These are the different stroke syndromes, and we saw these in the brainstem section here with Weber's, Benedict's, and Claude syndrome, and you can walk through them on the site. When it comes to the pons, key vessels are these pontine perforators here. Source artery is the basilar here. And then the clinical syndrome, which we've talked about in the brainstem section, is locked-in syndrome. And here is just a reminder of that. And this is an example of locked-in syndrome here. We can see hyperintensity here on the MRI indicating stroke throughout the pons in this anterior section here. And then this is the medulla here. Key vessels, again, we said were the anterior spinal artery and the pica. Source arteries here are the vertebral artery. Clinical syndrome, which we mentioned earlier, for instance, vertebral artery dissection can cause a branch occlusion of the pica, which causes Wallenberg syndrome. And again, we covered this syndrome itself in the brainstem section. This is the example of Wallenberg syndrome here, also known as dorsolateral medullary syndrome. This is the area of the medulla that's affected. Think pica stroke. Cerebellar vascular territories here, SCA, superior cerebellar artery up top, and then the pica down below, and then in the mid region, all three vessels cover various regions. And we can see this severe herniation here and compression in this posterior fossa. So where does it all come from? The aorta and its branches, the aortic arch, we have the carotids, and then we have the subclavian arteries. We have the descending aorta, which has a thoracic region above the diaphragm and an abdominal region below the diaphragm. At the aortic bifurcation, we have the iliac arteries, and then the ascending aorta feeds the coronary arteries here. Arteries of the head and neck itself. So the brachiocephalic trunk branches into the subclavian artery and the common carotid artery, and we can see that here, brachiocephalic trunk, subclavian here, common carotid here. And then the subclavian spits off the vertebral arteries, and the common carotid splits into the internal and external carotid arteries. You can see that here, external carotid, internal carotid. and then subclavian spitting off the vertebral arteries here. This is a quick sketch of this. So brachiocephalic trunk branches to common carotid and subclavian, and then the subclavian spits off the vertebral arteries, and the common carotid branches into the external carotid and the internal carotid. And then there's this caveat that on the left side, the carotid artery arises directly from the aortic arch. Finally, the veins of the head and neck. In parallel here, we have the subclavian and the internal jugular, which dump into the brachiocephalic vein. So internal jugular and subclavian dumping into the brachiocephalic vein, and we can see that here. Here's the internal jugular, and then the subclavian dumping in the brachiocephalic. So that's a quick run through of cerebral arterial supply. This is obviously core information for clinical practice.